Hello, welcome to the 7th podcast of Let's Revise MBBS, and today we are going to talk about pericardial diseases. Okay, so we will talk about three main diseases: acute pericarditis, chronic constrictive pericarditis, and cardiac tamponade. Okay, so before jumping on to the diseases, let's first talk about the normal functions of the pericardium. So as you know, we have visceral pericardium and parietal pericardium, and in between we have pericardial fluid, which is around 20 to 50 ml. Okay, so the normal function is to exert a restraining force on the heart so that it doesn't dilate too much when there is a volume overload, and it also restricts the heart to its anatomical position. Okay, and it also retards the spread of infection. Right, now let's talk about acute pericarditis. So as the name suggests, is acute. So the most common cause is idiopathic, we don't know, but the other causes can be viral, mainly because of Coxsackie B virus. Other causes can be TB, some drugs like procainamide, hydralazine. Okay, then we have fungal causes like histoplasmosis. Then we have some like renal failure. We have uremic pericarditis in renal failure. Then some neoplasms. Okay, so these are some causes of acute pericarditis. Now, there are four principal features of acute pericarditis. Those are chest pain, friction rub, some ECG findings, and pericardial effusion. Okay, so chest pain is similar to that of MI. So it is in the just below the sternum, retrosternal pain. It radiates to the left arm, jaw, and it also radiates to trapezius. The pain of MI does not radiate to trapezius, but the pain of acute pericarditis radiates to trapezius. Okay, and how will you differentiate this from the pain of acute MI? So some serum biomarkers like troponins or CKMB, these will be raised in MI, but they'll be slightly raised or they'll be almost be normal in acute pericarditis. Okay, now the second finding is friction rub. So it is like a rasping, scratching sound, and it is heard most frequently at the end of the respiration. Okay, now findings of ECG. Here, since there is inflammation of the pericardium, there is also inflammation of the some part of the epicardium. Okay, so there is acute subpericardial inflammation. Because of this, there can be ST elevation, widespread ST elevation. But the difference here is that the concavity which is there, it faces upwards. Okay, normally in MI, the concavity is downwards. If it is ST elevation of MI, then the concavity is downwards. Here, the concavity is upwards. Okay, one more thing from by which you can differentiate acute pericarditis from MI is you will get reciprocal changes in other leads, in opposite leads in MI, but you will not get reciprocal changes in acute pericarditis. Okay, so those are the two differences by which on ECG we can differentiate. Right, and the final is the pericardial effusion. So there is a fluid accumulation between the two pericardium, and this can lead to cardiac tamponade. Okay, there is a sign which is Ewart sign, EWART, Ewart sign. So we get a patch of dullness when we percuss just at the angle of the scapula. Okay, this is because the lungs get collapsed and atelectasis, and this is because of pericardial effusion. So we may get a dull note. Right. So for diagnosis, we mostly do 2D-CO, and it's a sensitive diagnostic tool by which we can diagnose acute pericarditis. And for treatment, we just give NSAIDs and aspirin. We can also add colchicine, because colchicine enhances the response of NSAIDs. Steroids are mostly avoided. Right, so that's about the treatment of acute pericarditis. Now let's come on to the constrictive pericarditis, chronic constrictive pericarditis. The most common cause of this is TB. Okay, other causes can be recurrent or relapsing acute pericarditis, Sjogren's syndrome, some malignancies. Okay, so what happens in constrictive pericarditis is, because of recurrent acute pericarditis, there is fibrosis of the pericardium. Okay, and obliteration of pericardial cavity, and there is formation of granulation tissue. Okay, so the pericardium becomes rigid and firm, you can imagine it like a metal container in which the heart is placed, right? So if you imagine this, most of the symptoms, most of the findings we can correlate with this, or we can imagine this and we can predict which all findings you can get. Okay, so now let's talk about JVP. So in JVP we have already seen there is X descent, which is rapid X descent. Okay, so here what happens is the normal in early diastole there is no impedance for ventricular filling. So in early diastole the ventricle relaxes, but then after that, after early diastole, there is abrupt limitation of the diastole or of the relaxation because of the thick or rigid pericardium. Okay, so we will get rapid Y descent, because rapid Y descent is because of ventricular filling. Okay, early ventricular filling. So we will get rapid Y descent on JVP. Okay, another sign is Kussmaul's sign. What is Kussmaul's sign? We have already seen. So it is normally during inspiration the JVP should decrease, but if it does not decrease or if it increases, then we say that it is Kussmaul's sign positive. Okay, this is because during inspiration there is more amount of blood coming into the right side, but that negative pressure is not transmitted to the heart because the pericardium is rigid. So more blood is coming on the right side, but the right ventricle is not dilating. Okay, because of this there can be increase in JVP. We can also get pulsus paradoxus in about 1/3 of the patient. Pericardial knock can also be heard. Pericardial knock is because the dilating ventricle hits the rigid pericardium. That's why we get pericardial knock. And one sign which is broadbent sign. So in broadbent sign is what? It is the apical pulse is reduced and there is retraction in systole, retraction of the heart, or retraction. You can see there is retraction between the skins of the ribs. Okay, so the pericardium is firmly attached to the just under the skin, just beneath the skin. So when heart contracts, there is retraction. Okay, so this is broadbent sign. We can also see square root sign of ventricular pressure pulse. Okay, the only definitive treatment for this is pericardial dissection. The prognosis is not very good, or you can say it's bad prognosis for constrictive pericarditis. Now coming on to cardiac tamponade. So in cardiac tamponade there is sufficient amount of fluid in the pericardial space which is enough to cause obstruction or serious obstruction to the inflow of blood into the ventricles. Okay, so this happens in cardiac tamponade. So there is a triad which is Beck's triad. The triad consists of hypotension, muffled heart sounds and raised JVP. Okay, hypotension is because there is reduced venous return, so reduced cardiac output, which can lead to hypotension. Muffled heart sound is because there is a lot of fluid in the pericardium, and JVP is raised because the ventricles cannot accommodate blood. That's why JVP is raised. Okay. Now on JVP, what we see is rapid X descent because atrial diastole or atrial relaxation is the only phase where filling takes place. So X descent is rapid, but there is no Y descent. Okay, we have seen this already. Then we get pulsus paradoxus. Why do we get pulsus paradoxus? So see, the free wall of the right ventricle, the pericardial fluid which is there, it is exerting pressure on the free wall of the right ventricle. So during inspiration, when the right ventricle is getting filled with the blood, it cannot dilate. The free wall of the right ventricle cannot dilate because there is fluid outside the free wall. So what happens is the septum, the interventricular septum shifts to the left side. Okay, so first there is going to be decrease in cardiac output because it's inspiration, and it will further decrease because the right ventricle is pushing the interventricular septum to the left side. So the difference between inspiration and expiration, which is 10 mm Hg, that will further be enhanced, and it will be more than 10 mm of Hg. That's why we see pulsus paradoxus. And what is the volume required for cardiac tamponade? There is no definite number. It can be anywhere from 200 ml to 2000 ml. So if there is sudden pericardial effusion, then even 200 ml of fluid can cause cardiac tamponade. But if it is chronic and the pericardium can stretch or has the ability to stretch, then even 2000 ml can show lesser symptoms than 200 ml. Okay, so it varies. Now on ECG, we will get low amplitude QRS complexes, and we will get alternating complexes of varying amplitude. Okay, this is because they said that the heart is swinging in the fluid. There is a pericardial fluid in which the heart is swinging from heartbeat to one heartbeat to the next. That's why we get varying amplitude of QRS complexes. Treatment for this condition is immediate pericardiocentesis. We can either do this by apical, parasternal or subxiphoid approach, but the subxiphoid approach is most commonly used. Okay. Now finally let's compare cardiac tamponade and constrictive pericarditis. Okay. So pulsus paradoxus, it is present in both, right? But it is more, or it is prominently seen in cardiac tamponade. Okay. Now in JVP, rapid Y descent is seen in constrictive pericarditis, not in tamponade. In tamponade, Y descent is absent. Rapid X descent is seen in both, but it is prominently seen in cardiac tamponade. Kussmaul sign is only seen in constrictive pericarditis, not in cardiac tamponade, because the negative pressure in the thoracic cavity can be transmitted through the fluid. Like if there is pericardial effusion and tamponade, still the negative thoracic pressure can be transmitted to the right heart. But in constrictive pericarditis, that's not possible. That's why Kussmaul sign is only seen in constrictive pericarditis. Then pericardial knock is also seen only in constrictive pericarditis. In ECG, in both the conditions, the voltage of QRS complex will be low, but electrical alternance, that is the varying amplitude of QRS complex for each heartbeat, will be different for cardiac tamponade, but electrical alternance will not be present in cardiac constrictive pericarditis. Okay. On echo, we will see thickened pericardium and pericardial calcification in constrictive pericarditis, and we will see pericardial effusion in cardiac tamponade. Okay. And in CT and MRI, also we will see thickened pericardium in constrictive pericarditis, right? And there will be any sign of thickened pericarditis in cardiac tamponade, right? So that's it. It was a short topic, and I think we have covered all the three topics, all the three diseases in detail, and these two are most important: cardiac tamponade and constrictive pericarditis. Right. So that's it. Keep studying and enjoy. Bye bye.